Thank you for inviting me to speak to you. And technology is really wonderful. You know, you see me speaking to you in your room, looking at you, and you wouldn't believe that I'm next door. I come from the north of England. That's where I grew up. My father's family were bakers and confectioners for generations. My mother's family worked mainly as weavers in the cotton mills, though her uncle actually emigrated to Canada and worked on the Canadian Pacific Railway. My grandfather, who was a baker, used to take me fishing sometimes, and I remember one day very particularly. I was about 9, it was summer, we were on the edge of a riverbank, and he turned to me and he said, "You're going to have opportunities that no one else in the family before you has had. Be the best you can be." I always remembered that, and like many of my generation, I was the first in the family to go to university. Sadly, he didn't see me become a doctor and have the privilege of sharing my patients' lives now for some 29 years. He died of a heart attack at the age of 72, but he also had diabetes and blood pressure. One of my patients has a similar constellation of diseases, but they're 85 and doing very well and living at home, and that's a transformation that we brought around in a generation. And my guess is many of you can bring into your mind's eye right now, you can see and think of a person who you look after or who you care for, who has a similar group of diseases. That set of people with long-term conditions currently consume 70% of health and care costs, some 76% of unscheduled admissions, and a majority of primary care consultations in our country. In the US, it's 93% of the Medicare and Medicaid budget. And the majority of those people have multiple conditions, as this slide shows you from Scotland. Looking at 1.7 million patient records, the majority of patients over 65 have 2 or more conditions, the majority over 75 have 3 or more conditions, the majority over 85 have 4 or more conditions, one of which probably makes them forget the other 3. So that is why I say that disease-specific pathways are a redundant strategy for the future that faces us. Because even now, only 14% of diabetics have just diabetes. Only 18% of people with COPD have just COPD. Comorbidity is our future, and that future actually needs to be recognized, because that person you brought into your mind's eye, you need to multiply by 252%, because that is where we are in 2050. That the rise in proportion of spend that people with multiple long-term conditions will take means that if people carry on as they are, the United States is the first country in 2065 on state projections will spend 100% of GDP on healthcare. Japan is second and we're middle of the pack. Now, in one sense, that's a nonsense statistic. It could never happen. But in another, it demonstrates the scale of the challenge and the tsunami of need that is facing us. So what is our current response? Well, you'll see from this slide that this is how we normally view ourselves as human beings. Though, in fact, if anybody is green sat next to you, I'd probably move. The health and social care system sees us, however, like this, as bits, as parts. And then we get really clever, because we put those bits and parts into different clusters, into different silos, and create specialist teams ahead of them. So the person in the house has what I describe as a Monty Python-esque queue of case managers outside a single person's house, because they only deal with one disease and the person inside has 3 or 4. Now, anybody who understands the literature on safety and reliability will recognise that that system has potential for poor handoffs, for poor communication and for errors. I am certain there are errors. We just don't know about them because we just don't collect that data. So how do we change it? Well, there are examples in many places of how you can begin to do this, largely based on Ed Wagner's chronic disease model, but work from Doug Eby in Alaska, in the Netherlands, in Sweden, in Scotland, in England. And when you look at that work, it can distill down to 3 key drivers. First, risk stratify your population with long-term conditions. That is, understand those who are most at risk of unscheduled admissions. Now, there are softwares that do this. They are different, but the algorithms are pretty much the same, which is the number of diseases somebody has, the number of drugs they're on, their socioeconomic status. Out of that comes a reliable list of people. Some people call that list of names a virtual wall, but it is a list of names. You then get that list looked at systematically, regularly, by an integrated care team in that geography, in that locality. Integrated between community services, primary care and social care. Social care being a key element for helping keep people well and at home. Choosing between them who is the person who is the best placed to be the coordinator for that person, but to actively look after them too. It may be the diabetic nurse, it may be the COPD nurse, but looking at the whole of that patient, doing what patients ask us to do. Because if you look at the surveys, they say, I want you to deal with the whole of me, and I want you to act as one team. And that is what we're trying to put in place. The third element, and the most difficult for people I've found in changing mindsets, is to systematize and maximize the number of people or their carers who can co-manage their conditions. That's not just because it's a nice thing to do, but the literature is full of the evidence that it improves the clinical outcomes, and that just makes rational sense when you think about it, because people have to look after their own condition for some 7,990 hours in a year, whereas they interact with us professionals for some 6 or 7. So giving them the knowledge as to what to do in that 7,990 hours does help in terms of keeping them weller longer, keeping them out of hospital, and as I say, maximising the clinical outcomes. It is more efficient for the healthcare system locally, and it is increasing the capacity of the healthcare system by embracing the users of it. And the fourth element is to put them all in place. It's not pick and mix, to put them all in place. So integrated care teams, risk stratification, maximising self-care, and put them all in place. But just changing the care model is insufficient. We need to change the financial flows to reinforce the care model to make it sustainable. And that is what we're also seeking to do right now. We're creating a year of care risk-adjusted capitation model for the tariff for managing people with long-term conditions. Now, what does that jargon mean in English? What it means is we're actually looking at the risk profile of groups of populations, high, medium, low, based on those evidence risk stratifications. And we're looking at the cost of the care for those people across the care continuum. And then we're going to say, we're asking providers to either work collectively together or a lead provider and subcontractors to provide a year of care for those people. This transcends primary community up to hospital care, but it means that the incentives to maintain income are maximised if you're looking after people at home. The first Part of this will be available in April 13, but the full version probably 2014. We're not going to get this completely right first time, I'm sure, but the principle is really key, and I think this could potentially be a game changer. The other financial change we're making is to the quality and outcomes framework that currently represents around 30% of GP's income in England, where we're getting these three drivers, or we're negotiating for these three drivers to be included as part of that quality and outcomes framework: risk stratification, integrated care, and helping people maximise their self-care. We have this development programme now covering clinical groups over 35 million of the population in England. I didn't expect us to start to see results, if I'm honest, until around 2014, because to get every practice doing risk stratification, maybe 12 months, about 18 months to get integrated care teams fully up and running. And I have to tell you, just in case you're wondering, that actually to create integrated care teams doesn't cost any money. We can demonstrate that. It's simply making the same people work differently. But we're already seeing areas in the country of 24% reduction in unscheduled admissions, similar amounts in length of stay. We're already seeing other places in double digits. More are coming on stream. Areas of the population, southwest for example, where 50% of their whole area is now covered by integrated care teams and risk stratification. I am optimistic that we will really start to change the way that we manage people with long-term conditions, not just to the benefit of the health system, but actually, most importantly, for patients themselves. As I said earlier, every industrialised country healthcare system faces this challenge. No one will escape it. Status quo is not an option for any of us. If we fail, it's not that we're failing our governments or our healthcare organisations or our hospitals or our practices. We're failing the person you brought into your mind's eye. We're failing our friends, our relatives, our communities. We cannot allow that to happen. We must be the best we can be. Thank you.